From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to this JAMA podcast. I am Mary McDermott, Deputy Editor of JAMA, and I am here today with Dr. Frederick Ruberg, who is the Thomas J. Ryan Professor of Medicine and Chief Section of Cardiovascular Medicine at Boston University, Chobanian and Avedisian School of Medicine and Boston Medical Center. Today, we will be discussing Dr. Ruberg's recent narrative review about cardiac amyloidosis due to transthyretin protein published in JAMA. Welcome, Rick. Thank you so much for joining us.
Thank you, Mary. It's a delight to be with you today.
So let's start by having you tell us what is cardiac amyloidosis due to transthyretin protein.
Sure. So amyloidosis is a disease that results from deposition of misfolded protein. And we classify the systemic amyloidoses by the protein that misfolds. For cardiac amyloidosis, there are really principally two types of proteins that misfold: light chain, also known as AL or amyloid light chain, and TTR or transthyretin, also known as ATTR amyloidosis. So ATTR cardiac amyloidosis is amyloidosis of the heart that results from deposition of misfolded transthyretin protein that aggregates as amyloid fibrils and deposits in the cardiac tissue.
What is transthyretin protein?
Transthyretin protein, also known as prealbumin, is a circulating transport protein for thyroid hormone and retinol, vitamin A, and the retinol binding protein 4 complex. It's not actually a particularly important transport protein for thyroid hormone, but it is an important transport protein for retinol, and it principally exists in the circulation.
What are typical symptoms of cardiac amyloidosis?
Cardiac amyloidosis typically manifests as congestive heart failure. Congestive heart failure typically manifests as shortness of breath, fatigue, low blood pressure, lower extremity edema, and features of congestion in the lungs or the lower extremity circulation. Patients typically present later in life with ATTR amyloidosis. It's a disease associated with aging, and oftentimes it can be difficult for a clinician to identify because it may develop superimposed upon other processes such as hypertension or aortic stenosis that might prompt the clinician to attribute a patient's symptoms of congestive heart failure to these other conditions. Cardiac amyloidosis can also present as heart rhythm problems that are typically associated with congestive heart failure, such as atrial fibrillation or heart conduction disease problems, AV block, that may require a pacemaker.
Does cardiac amyloidosis due to transthyretin protein typically present with heart failure due to preserved ejection fraction or heart failure due to reduced ejection fraction, or both?
It can present as both. Early on in the course of disease, ejection fraction is preserved, and most cases that are identified of ATTR cardiac amyloidosis are preserved ejection fraction. But as the disease progresses, ejection fraction drops. Lower ejection fraction is a manifestation of more advanced disease, but predominant cases that are identified are preserved ejection fraction.
How is cardiac amyloidosis due to transthyretin protein typically diagnosed?
Historically, this disease required a tissue biopsy, typically an endomyocardial biopsy, to make the diagnosis. But over the past 7 to 8 years, I would say, we have begun to rely more heavily upon non-invasive imaging techniques to make the diagnosis. Since cardiac amyloidosis results in thickening of the heart wall muscle by deposition of the amyloid protein, that thickening of the heart wall muscle can be identified through more sensitive techniques such as cardiovascular magnetic resonance or sensitive echocardiographic techniques. But the principal way in which we make the diagnosis without the need for an endomyocardial biopsy is with specific nuclear imaging radiotracers. These radiotracers typically are bone-seeking, but they also identify deposition of amyloid in the heart. In the United States, the most readily available tracer is technetium pyrophosphate, but also available is technetium, it's called HDP or HMDP, a different radiotracer that can identify amyloidosis. So by looking at the signals created by the radiotracers in nuclear imaging and combining that with additional blood testing, which is used to exclude the presence of AL amyloidosis. A diagnosis of ATTR amyloidosis can be made without the need for a tissue biopsy.
So I'm a general internist and I have patients with heart failure. When should I suspect cardiac amyloidosis and what type of workup would I do?
So that's an excellent question because cardiac amyloidosis is not a common cause of congestive heart failure compared to, say, hypertension or coronary artery disease, which are much more prevalent diseases and more likely to be encountered by the clinician. But cardiac amyloidosis may cause 5 to 10% of cases of congestive heart failure in older, particularly older patients, say over the age of 60 or 70 years of age. Cardiac amyloidosis often is associated with other manifestations of systemic amyloid deposition. One of the areas that's been recently recognized is deposition of amyloid protein in ligamentous structures, such as the ligamentum flavum in the back causing spinal stenosis or the flexor retinaculum causing carpal tunnel disease. So patients who may have convergence of, say, carpal tunnels, bilateral carpal tunnel syndrome in particular, spinal stenosis and heart failure in an older individual should prompt consideration of amyloid disease. Other scenarios might be a patient who has evidence of echocardiographic increased wall thickness, which typically results from hypertension, but in the absence of hypertension or aortic stenosis or another cause, then amyloid heart disease would be another consideration.
Can you tell us about the first-line treatments for patients who have cardiac amyloidosis due to transthyretin protein? And I wonder if you could start by telling us whether the heart failure treatments differ from what we would normally prescribe.
Absolutely. So the mainstay of treatment in cardiac amyloidosis is decongestion and volume control. And we typically achieve that by loop diuretics. Furosemide, torsemide, bumetanide are the most common agents that we would utilize. These agents are quite successful in reducing the circulating volume, as you would for a patient with non-amyloid heart failure, and making the symptoms of congestion better. In cardiac amyloidosis, there's also good evidence that mineralocorticoid antagonists, such as spironolactone or eplerenone, are also quite useful. And this is also similar to standard congestive heart failure management. Now, where care of the amyloid patient with heart failure is different from the care of the non-amyloid patient with heart failure is in the typical guideline-directed medical therapy that we otherwise would initiate for heart failure. In the case of reduced ejection fraction, we would rely on angiotensin receptor neprilysin inhibitors or SGLT2 inhibitors or other agents. These agents are not proven to be effective in amyloid heart disease, although there is insufficient evidence in some cases because amyloid disease is a relatively rare diagnosis and the degree of evidence and the quality of evidence that demonstrates efficacy is limited, more limited than in other forms of heart failure. But typically we would start with a loop diuretic, mineralocorticoid antagonist, and then consider additional therapy. The use of SGLT2 inhibitors is intriguing. There isn't sufficient evidence now to suggest that all patients with amyloid heart disease should receive these medications, but owing to the interest in non-amyloid heart failure, there is significant attention paid to those agents in particular for amyloid heart disease.
Are there therapies available that can prevent the transthyretin protein misfolding and prevent progression of this condition?
Yes, and this was not the case until about 4 or 5 years ago. So the strategies that are directed against amyloid protein in specific, and we call these disease-modifying therapies as opposed to therapies for heart failure, can be categorized in 2 principal categories presently. One category are inhibitors of TTR misfolding. So these are orally available therapeutics that a patient takes once or twice a day that bind and slow the misfolding of the TTR protein, thereby slowing the progression of the disease. It doesn't do anything about already deposited amyloid in the heart, but it slows the progression of disease. The other class of therapeutics are agents that suppress or knock down production of TTR protein. These approaches use different therapeutic strategies, including small interfering RNA or antisense oligodeoxynucleotides that are administered either intravenously or subcutaneously to induce the liver to stop producing TTR protein almost entirely. Usually it's about an 85 to 90% knockdown of protein. And by removing TTR from the circulation, the misfolding process also is slowed and or stopped, resulting in improved outcomes. The TTR therapeutics that are approved for cardiac amyloidosis in 2024, there's only one, and that's the drug tafamidis at the time of this recording. That said, a number of other agents have been recently reported or are in clinical trial that potentially will also be effective in ATTR cardiac amyloidosis. Agents that are available that suppress TTR protein have been approved for ATTR polyneuropathy, a related disease where transthyretin protein deposits in the nerves. But these agents haven't necessarily been specifically tested in ATTR cardiomyopathy as of yet.
Earlier in the interview, you referred to arrhythmias that can occur in patients who have cardiac amyloidosis due to transthyretin protein. I wonder if you could talk a little bit more about those and whether the arrhythmia frequency or nature differs compared to someone who has heart failure without amyloidosis.
Yeah, so the most common arrhythmia in ATTR amyloidosis is atrial fibrillation, which is also the most common arrhythmia that exists, actually. And in heart failure, there's a strong concordance between the two. But in ATTR cardiomyopathy that causes heart failure, the concordance is extremely high, such that the patients with ATTR amyloidosis, particularly wild-type ATTR amyloidosis, I'm happy to explain what that means in a moment, potentially 80% or more of those patients will have atrial fibrillation. In such patients, there's requisite anticoagulation. The CHADS-2 VAS score, which we use to determine the efficacy and safety of anticoagulation in patients with other forms of heart failure or other diseases, doesn't really apply in ATTR amyloidosis. And so we anticoagulate patients who have ATTR amyloidosis and atrial fibrillation because of a very high concordance of the presence of intracardiac thrombi and thromboembolism. So anticoagulation is requisite, and we also have observed that the treatments that are attempted to restore heart rhythm tend to be less effective in this disease as well compared to other forms of heart failure. Medications such as amiodarone are the most commonly used arrhythmic in this disease, and ablation therapy is something also that is receiving increased attention. But generally, catheter ablation is something that tends to be quite effective for atrial flutter in ATTR amyloidosis, but atrial fibrillation, the results have been mixed.
And to clarify, do you anticoagulate all patients with cardiac amyloidosis from transthyretin protein, or you wait for them to get the arrhythmia?
So we do not anticoagulate all patients with ATTR amyloidosis if they do not have atrial fibrillation, only if they do have atrial fibrillation. My approach is to actively survey patients if they do have ATTR amyloidosis and do not have atrial fibrillation with longitudinal monitoring or other means because of the high concordance rate and my wish to avoid missing a stroke event for occult atrial fibrillation.
And can you go back to the mention of wild type compared to gene variant and talk a little bit about that?
Absolutely. So ATTR amyloidosis is subdivided into the genotype of the TTR protein. And I alluded a moment ago to wild-type ATTR. In this particular case, the code for the TTR protein are normal. There are no variants. But there are a number of inherited variants that can occur in the TTR protein that could be associated with the development of ATTR amyloidosis, and we consider these risk variants. The most common variant in the United States, and actually worldwide, in fact, when you look at the total numbers of cases affected, is a variant called VAL122ILE, or V122I, also known as PV142I. It's confusing. They all refer to the same variant location. This variant exists in about 3.4% of people who identify as Black in the United States, which translates into 1.5 million or so risk carriers, extrapolating from the U.S. Census figures. And so we know that there are 1.5 million people at least walking around with a risk variant that can result in the development of TTR amyloidosis, but we don't know what proportion of those people who carry that variant are going to develop the disease. Wild type is not genetically inherited, and it's not tested for genetically. Wild type amyloidosis is probably the more common type, but again, as I mentioned before, evidence is not strong enough to say definitively what proportion of V122I or VAL122ILE patients who carry allele will ultimately develop amyloid disease. We do know that there is strong evidence that the presence of the allele is associated with an increased risk of heart failure over time.
So this has been a really informative discussion, Rick. Is there anything else you'd like to add?
Thank you for the opportunity to discuss this recent publication. I would like to add that evidence suggests that the therapies, which are emerging even more options every day, it seems, but the therapies that are most available are best administered and most effective when patients are identified early in their disease course. And so It's important for the clinician to understand the signs and symptoms of ATTR cardiac amyloidosis and to understand when would be the appropriate time to refer a patient for testing so that patients can be identified early and have the advantage of receiving treatment at a time when the treatment can be most effective in prolonging their survival, keeping them out of the hospital with heart failure, and improving their quality of life.
Thanks for listening. This is Mary McDermott, Deputy Editor of JAMA. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.